Hello friends, welcome back to Dr. Arshad Nadeem Awan ultrasound and radiology teaching videos. Hope you're all okay and you're also enjoying your life and you're also enjoying watching my videos. As you know that these days I'm discussing about the musculoskeleton system, in which a lot of benign tumor has been already discussed, and now I will discuss about the malignant tumors of the bone as well. But before going to that, this video would be really worth watching because this is very important, and it will show you certain fingertips points, home take points, that how you will evaluate bone tumors on the x-rays. Like the age of the patients is important, like the location is important, like the zone of transition is important, like how it will behave on the x-rays, how the bony pattern, destruction pattern would be there, how the periosteal reaction you will evaluate. Beside this, you will also evaluate whether there is some soft tissue expansions or not, what would maybe the size, whether it is polyostosis or monostosis. All these points has been discussed at length, so this is very important and vital video for those who are radiology trainee or those who are doing radiology, especially in the bone or especially in accident or trauma. Not particularly in accident and trauma, but still it is very important. On the basis of these x-rays and these few points, it will widen your canvas of diagnosis and differentials as well. So let's start watching this video. For the evaluation of the bone tumor on the conventional radiograph, there are certain important points should be taken into account. The first and the foremost is the age of the patient, because certain diseases are classically presents in first decade of life, in second or third decade of life. For example, in first and second decade of life, a simple bone cyst is very common. Ewing sarcoma in the children is very common. So for the second and third decade is concerned, chondroblastoma, non-ossified fibroma, osteochondroma, these are the commonest one. In the third, fourth decade of life, there is giant cell tumors are very common, and aneurysmal bone cysts are also very common. In later life, there is likely possibilities of hemangiomas and chondrosarcomas and multiple myelomas and chordoma. So therefore the age of the patient is very much important. While you are starting evaluating the bone tumor on the x-rays, always ask for the relevant history, especially the age. So always look for the age and any changes of the bone related to the skeletally mature patient or a skeletally immature patient, or always look for the fusion of the growth plate. Next comes the location of the lesion. Always look for the type of the skeleton involved, whether it is axial or it is appendicular or it is any particular bone is involved, like for example tibia. So admentinoma is very common, chondromyxoid fibroma is very common. Always look for these points. Look for the longitudinal axis, whether epiphyses are involved or metaphyseal or diaphyseal. So these are, it is metaphysio diaphyseal. So for example, the enchondromas are concerned, it happens to be metaphysio diaphyseal. Beside this, always look for the transverse axis, whether it is central or excentral or cortical. For example, osteoid osteoma, osteoblastoma happens to be cortical. And so for the central is concerned, this is fibrous dysplasia or simple bone cyst can be central. Or so for eccentric is concerned, aneurysmal bone cyst are usually be eccentric. Next comes zone of transition. Zone of transition is very important. You have to look for whether it is narrow zone of transition or it is wide zone of transition. Certain lesion has a characteristic of having wide zone of transition, some of them having a narrow zone of transition. So it is actually the difference between the normal and the abnormal bone that means that the zone of transition, whether it is clearly differentiating between the normal and the abnormal bone, this would be considered as a zone of transition. So always look for the zone of transition, whether there is a narrow zone of transition or whether there is a wide zone of transition. Another important point is you have to look for the margins of the lesion, whether the margins of the lesions are smooth or these are irregular. Most of the time smooth margins shows non-aggressive behavior, and if there is irregular margin, so it shows malignant transformation in aggressive pattern as well, especially when there is infection or there is some carcinomatous or malignant changes. It will always be appear with irregular margin, and smooth margin denotes non-aggressive pattern, like in a simple bone cyst there will be smooth margin and it will be a diaphyseal, it will be centrally, so therefore margins of the lesion must be looked after. Very important and worth noting point is that one should have to look for the presence of tumor matrix. Tumor matrix are classified into three categories. It may be osseous, it may be chondroid, or it may be fibrous. Like in osseous matrix, it would be seen in osteosarcoma, while chondroid matrix can be seen in osteochondroma and in chondroma. And so far the fibrous matrix is concerned, it will appear as a ground glass, and it is usually seen in fibrous dysplasia. Pattern of the bone destruction is another very important feature, which will also denote the aggressive and non-aggressive pattern of the bone tumors. So again, these patterns could be of three types: geographical, moth-eaten, and permeative. Geographical bone destruction will be appear as a well-defined or map-like structure. It will shows a very less aggressive pattern, like in GCT and in simple bone cysts, so it will be geographical appearance. In moth-eaten, it will look like a hole with less defined margins, and this shows more aggressive patterns, usually seen with metastatic deposits, with lymphoma and Langerhans cell histiocytosis. The third very important and very worth noting point is permeative pattern. It is poorly demarcated pattern. Quite often you might ignore on the X-rays, but one should be very much vigilant to look for the permeative pattern. It is a very aggressive pattern and can be seen only in Ewing sarcoma and in lymphoma. The important points: the periosteal reaction is very common, and everybody should pay attention to. Multiple types of periosteal reactions are, but mainly whether you have to look whether this periosteal reaction is of solid type, or it is multi-layered, or it is vertical. So these are the three very important points. So far the solid periosteal reaction is concerned, it can be seen in osteoid osteoma. In multi-layered, it can be seen in Ewing sarcoma, and in vertical, which is also called as sunburst speculation, or in other words called as an hair on ends. So this can also be seen in more aggressive tumors of the bones. The cortical response should always be looked, and there are 5 points for the cortical response. It may be expanded but intact. It shows slow growth, like in chondroma they will be expanded, medullary expansion will be there, but this cortical outline would be intact, there will be no breach. Endosteal scalloping is another form of the cortical response, which can also be seen in chondromas and in chondrosarcomas. Trabeculation pattern also indicates slow growth, especially can be seen in non-ossifying fibroma and CMF and aneurysmal bone cyst. Joint cell tumor will also appear as a trabeculated patterns. Destroyed cortical response can be seen in rapid growth, especially in telangiectatic osteosarcoma, and cortical sessurization is the another point. So these point must be noted so far the cortical response is concerned while reporting the X-ray, especially for the MSK tumors. Soft tissue involvement is the another important point while evaluating the bone tumors, whether there is any soft tissue involvement associated with the bone tumor. Like in Ewing sarcoma, there will also be soft tissue component. In case of telangiectatic osteosarcoma, there will also be soft tissue component like Maffucci syndrome. We have also seen there will be associated soft tissues masses with hemangioma. So soft tissue involvement should also be monitored while reporting the bone tumors. So far the size of the lesion is concerned, although it has not great importance, especially in case of few examples are there, like in osteoid osteoma and osteoblastoma, the size matters for the differentiation of the two diseases, but mainly there is not much difference, especially in non-ossifying fibroma and fibrous cortical defect. So a few cases and examples are there. The list is not very large and very exhausting, so it is not very worth point, but still you have to pay attention to the size of the lesion as well. The last point is whether it is whether this tumor is monostotic or polyostotic, whether it has only a singular or involving a one bone, or it has involved multiple bones. Like there are multiple bones involvement in benign lesions, or fibrous dysplasia happens to be monostotic, Paget's disease, multiple enchondroma like Ollier disease or Maffucci syndrome, multiple osteochondromas, and the same malignant and aggressive polyostotic lesions can be METs. METs will not be monostotic, can be, but not really. Most of the time it would be polyostotic. Multiple myeloma, aggressive stage of Paget's disease, and multifocal osteomyelitis will also appear as monostotic. So I do hope there will be no doubt left evaluating the X-rays, especially related to bone and in orthopedic departments, radiology, orthopedic radiology. So just memorize all these points, because these are very vital and important and baselines. So whenever you are evaluating any of the tumors on the X-ray, you should have to have all these points in view. So hopefully with some other new information and new video, we'll see each other. Till then, take great care of yourself. Bye bye.